Okay, so shall we start for today's discussion?
Excuse me, sir.
Yeah, yeah.
I think few people are joining. So few doctors are
Okay.
joining. So can we have 3-4 minutes more so that
Yeah, yeah. Of course, we can wait. We can wait.
yes. All right.
Since the session also gets recorded, maybe we could start in time and finish in time, Mr. Imran.
I mean, I don't have any problem. Is whatever the opinion of all of you, I'll
Because
go with that.
in PJ Chandigarh, we used to start session at 8 a.m. sharp,
Yeah,
whether
yeah.
there are
Of
two
course,
people there
of
or
course.
three people there.
Yeah, yeah. Of course, very true.
Okay. No problem from my side. I will admit participants who are entering. So, sir, yeah, if all are okay, then we can
Okay.
start.
Okay. So, friends, in the last class, we discussed about the different kind of mechanisms that regulate the sleep and the wakefulness. And we also discussed about the functions and the sleep and why the sleep is important. So, moving a step further, today we'll try to discuss what is actually the insomnia and how to say what is the actually clinical importance of the insomnia. So, we will discuss the epidemiology of the insomnia, so how common this is, then we'll discuss about the data regarding the say Indian subcontinent. Then there has been some changes in the definition of the insomnia. How do we diagnose insomnia? Uh, how do we define insomnia? So we try to understand what are those concepts and the logic behind those concepts. Then we all know that insomnia is a medical disorder. So for any of the disorders, there are certain people who are at greater risk. So we'll try to find out who are they. And lastly, we'll examine what does the literature say if we do not treat insomnia. So, if we talk about the epidemiology of the insomnia, so there have been a number of studies across the globe and even in India, but uh, all of them they have give a different estimate of the people suffering from insomnia. And why is that? Because there has been a difference in the definitions of the insomnia. Some people have taken insomnia just as a symptom. So they have simply asked whether you are having any trouble in falling asleep or staying asleep. Other peoples, they have looked insomnia as a disorder. So they have also, besides the nighttime symptoms of difficulty falling asleep, staying asleep, or waking up earlier than the desired wake time, they have also looked at the daytime consequences of insomnia at night, and which include the heaviness in the head, which is generalized, poor concentration, irritability, lethargy, fatigue, and inability to say do the daily chores. So these two definitions, though they seem similar, but they are actually different. If you are not asking about the daytime consequences, you cannot say that this is actually a disorder, because a number of people they may have difficulty falling asleep or staying asleep and waking up earlier than the desired wake time at night, but all of them they do not suffer from the daytime consequences. So if there are no daytime consequences, then we say that it's just a symptom, it's not a disorder. But if there are daytime consequences, then we say yes, this is in a disorder. Second issue is that the definitions were heterogeneous with regards to the duration. So some of the studies they have asked for the say insomnia symptom or insomnia disorder during past 1 week or maybe past 1 month or maybe past 1 year. Then the studies they have specifically looked for the different types of insomnia. So, insomnia, which is causing the difficulty in falling asleep, or it's known as also known as early insomnia or the initial insomnia. Then there are people who wake up in between the night and then they are not able to fall asleep again, or they may be having multiple awakening at night. So this is known as middle insomnia. And lastly, some people they wake up earlier than their desired wake time, and that is something which is known as terminal insomnia. So studies they have focused on either the initial insomnia or middle insomnia or the terminal insomnia. Then some of the studies they try to look at the etiology of the insomnia. For example, insomnia which occurs along with depression, insomnia which can be attributed to the alcohol withdrawal or a recent stressor. And lastly, and most important, say concept that we need to understand is that the symptoms as well as the severity of the insomnia it fluctuates over time. You won't get any patient there who would say that, look, doc, I'm not able to sleep for past 1 month or maybe 3 months or maybe 1 year every night. Most of them they would say, look, doc, I'm having difficulty falling asleep or staying asleep or wake up earlier than the desired wake time. But this happens maybe 3 nights a week, 4 nights a week, 5 nights a week, or maybe 6 nights a week, or maybe then you ask about the nights in a month, then he would say that, look, it occurs maybe 15 nights a week or 20 nights a week. Sometimes I'm actually I'm not able to fall asleep at all, and at other times when I lie down on the bed, I have the delayed time to go to sleep. So such kind of fluctuation of symptoms and the severity, that is what is clinically observed as insomnia. And because of these factors, the estimate regarding the prevalence of insomnia, they also vary across these studies. Then there have been a number of different classification systems, international classification of diseases, which is proposed by the World Health Organization. Then there is a diagnostic and statistical manual, which is proposed by the American Psychiatric Association. Then there is international classification of sleep disorders, which has been proposed by the American Academy of Sleep Medicine. And in the till 2013, all the three different classification systems, unfortunately, they had different definitions for the insomnia. And the definitions, they varied in terms of the frequency, the symptoms, the duration. So that also led to the difference in the estimates of the epidemiology of insomnia. Then, in many studies, the insomnia was diagnosed based on the questionnaires. And we all know that questionnaire-based studies are never a foolproof method for the assessment of any of the diseases. And they always have a bias, especially the recall bias, and which is also governed by the present mental state of the patients, the recent symptoms. So if a person is presently undergoing an episode of insomnia, he may recall that he would be, because of the recall bias or cognitive changes, he would feel that he would be having symptoms, say, for 1 year or 2 years. So that kind of, say, problems they had across different studies. Then some of the studies they use the self-made questionnaires. So they use different time frame, for example, past 1 week, past one fortnight, past 1 month, or they ask for they differ in the frequency of the symptoms that you should give respond to having insomnia. Yes, only if you are having the problem at least 1 night a week, or maybe 3 nights a week, or maybe 5 nights a week. And some of these studies, they tried to include the daytime dysfunction that we discussed, which occurs with the insomnia, um, in the self-made questionnaires. So when we look at the different assessment methods, so if we just simply ask the patient, do you have insomnia? Then they have it kind of subjective reporting, though we say on the face value, we rely at least on the clinical for the clinical diagnosis, but for the research, there is an element of the recall bias. And the information which is being provided by any of the patient or any of the person is usually influenced by the present state of mind, the present state of um, the problems that he or she is facing. Then, when we talk about the insomnia, number of other sleep disorders, they can also mimic insomnia. For example, a person who is having delayed sleep phase disorder. So he goes to bed late in the night, he wakes up late in the morning, but he spends around, say, adequate time in the sleep, which can be 6 hours, 7 hours, or 8 hours, and he does not have any daytime symptoms till the time he or she is allowed to follow his or her own sleep wake schedule. Similarly, you must be getting old people who would say that they are having that they have difficulty in sleeping, and they wake up earlier than the desired wake time in the morning, and they wake up by, say, 3 o'clock, 4 o'clock. But if you examine their sleep wake schedule, you would find that they sleep at around 9 o'clock. So actually, they are having spend or maybe spending 7 to 8 hours or 6 hours in the sleep at night. And if they are allowed to they follow their own sleep wake schedule during the daytime, they remain awake and alert, and they do not have any daytime consequences of the insomnia. Similarly, people who are suffering from restless sleep syndrome, they can also complain of difficulty falling asleep. So these kind of disorders, because many of the patients, they do not realize that they are suffering from these disorder, so they may provide a wrong information suggesting that they were suffering from the insomnia. Similarly, time frame, if we ask, as we have discussed, so it is very, if we, the longer the time frame, greater the recall bias. And the more the sleep complaints are important for the patient or the person, he give extra salience to those problems, and that leads to the overestimation of the insomnia. Then some of the studies, they have used the objective methods like sleep diary. So sleep diary is just a paper and pencil method where if the person records when did he go to bed, how much time did it take to fall asleep, and how many times did he wake up in the night, how much time did he spend awake during each of the awakening, and at what time did he wake up finally in the morning. So that estimates the sleep onset latency. Sleep onset latency means time to fall asleep after laying down in the bed with the intention to fall asleep. Second, VISO is basically awake after sleep onset. So once the person falls asleep, after that, how much time does he spend awake in just one awakening or maybe multiple awakenings? And third is the TST, is the total sleep time. That means how much time did the person spent in the sleep during the whole night. So this sleep diary gives a good estimation of these three measures, which can actually, and which is, this has to be filled every day, so that can reduce the recall bias. Then other studies, they have used actigraphy. Actigraphy is basically a watch-like instrument which is to be worn on the non-dominant wrist, and as the name suggests, it measures the activity. So periods of quiescence of the activity, they are considered the periods of sleep, and the periods of activity are considered the periods of wakefulness. So we usually record the data for 2 weeks and sometimes longer, and that based on that chart, we can see whether the person was sleeping or not. And third objective method is polysomnography. We'll discuss about the sleep study in the subsequent lectures. But the problem is you cannot make a person sleep in the night in a sleep laboratory for an extended period of time, say 14 days or a month. So that's a cross-sectional examination of maybe one night or 2 nights, because that's quite labor intensive, expensive. So, but of course, that's a gold standard, and that gives us almost very good data regarding the sleepiness, because we are say deciding the sleep and the wakefulness based on the EEG patterns that we capture whole night. Now, if we look at the correlation between the subjective versus the data from the sleep diary, it is poor. But if we look at the correlation between the sleep diary and the actigraphy, this has varied across studies. Some of the studies, they have mentioned that the sleep diary data is as reliable as the data from the actigraphy. And the other studies, they have found that there is a poor correlation between the data of the sleep diary as well as the actigraphy. So for the even for the clinical purpose, because of the variability in the literature, we, even when we are recording the actigraphy parameters from a patient, we use sleep diary as well. So with this background, we examine the prevalence of insomnia. So if we talk about just the symptoms of insomnia, do you have difficulty falling asleep? Do you experience middle insomnia, or do you experience terminal insomnia? Just you ask this one question, then you would see that prevalence in the general population would go somewhere between 35 to 40%. If you ask about the symptoms of insomnia, and also if you add the frequency criteria or the frequency measure, that the symptoms, they occur at least 3 nights a week, then the prevalence of the insomnia using this definition would reduce to somewhere around 18%. And if you actually ask the patient that, look, I understand you are having either the initial, middle, or terminal insomnia at night, but the more important part is, do you have any kind of trouble during the day because of nighttime problems? And if you use this definition of insomnia, then the prevalence would reduce to somewhere around 10 to 12%. And the last one, the nighttime symptoms plus the daytime consequences, if they are present, then only we can say that the person is having clinical insomnia or a diagnosable insomnia. Or we can say that, yes, look, this is now the insomnia disorder which requires some kind of management. Of course, at the same time, you should also realize that insomnia usually starts as a symptom, which usually increases in frequency, and then it becomes a disorder. So it's also an evolution of the disease. But if we use this definition for the insomnia, then you would see that the nearly 10% of the adult population, they suffer from insomnia. So look at the Indian data. This one study from Panda, it was done from the relatives of the patients who were attending the clinics in southern India. So they used some sleep disorders pro forma. The average age of the participants was around in their 40s, 30s to 40s. Male to female ratio was almost 1.2 to 1, and they found that 18% of the participants, they were suffering from insomnia. Another study, very recent, where which was almost a kind of house, which was a household survey of people aging more than 45. So they used non-validated questionnaires and they just looked at the insomnia symptom. And they found that nearly 13% of the participants, they were suffering from insomnia. Kumari et al. In 2018, they did a community survey in a rural area using the insomnia symptoms questionnaire. So they found that nearly 13% of the participants, they were suffering from insomnia and they were having insomnia symptoms. We also did a community survey in Uttarakhand near Dehradun. It was a household survey, and we used insomnia severity index to classify insomnia. And we found that nearly 10% of the participants, they were reporting insomnia. So if we go by these 2 or 3 studies, we can say that in India, approximately 10% of the adults, especially in the community, who are not suffering from, may or may not be suffering from any kind of medical disorder, other medical disorder, they are actually, they are suffering from insomnia. Now, friends, just imagine the number of patients that you have to treat who are suffering from insomnia. Considering that we are having nearly 50 crore population who are falling in the age bracket between 30s to 50 or 50s and 60s. So if we look at 10% of that population, so we have 5 crore patients of insomnia in India, and that's actually a fairly large population. If we look at whether the gender, they have any kind of influence on the insomnia, so it has been found that the females, they are more vulnerable to insomnia compared to the male. And this gender difference has been seen in the pubescent girls as well as in the after the puberty till old age. So there was one theory that females are predisposed to insomnia by virtue of the female gonadal hormones and its cyclical nature across the menstrual cycle. But since this difference is also seen in the prepubescent girls, so that theory has been refuted in part. So we are not really sure whether there is a why the females are more prone or more vulnerable to insomnia compared to male. If we talk about aging, we all know that as we age, the prevalence of insomnia increases. So prevalence of insomnia is least in the adults. And as we age, especially as we cross 40s, the prevalence of insomnia disorder, it increases. At the same time, severity of the insomnia, severity means the difficulty that a person is experiencing in either falling asleep, maintaining the sleep, or waking up earlier than the desired wake time, and the daytime consequences of nighttime symptoms. Their severity or negative impact also increases. Very importantly, as we age, there is a neurodegeneration. The brain becomes less resistant, or say it loses its capacity to fight with any kind of changes. So the insomnia becomes more persistent as we age. And at the same time, there are another factors which could lead to the increase in the prevalence of insomnia with the aging. For example, the other medical disorders. If a person is suffering from diabetes or maybe acidity or maybe osteoarthritis or maybe any other reason which is causing pain abdomen or pain anywhere in the body or discomfort in the body, so he might be suffering from primary symptom or maybe given some kind of medication. So because of the combined effect of either the symptom, the disorder itself, or because of the effect of the medication, there could be a change in the sleep and wakefulness state, and that could precipitate insomnia. Similarly, the prevalence of other medical disorders, or maybe we can call the psychiatric disorders, also increases with age. Depression, anxiety, its prevalence increases with the age, especially in the 30s to 50s. And we all know that insomnia is one of the major symptoms, or maybe now we say that insomnia in many of the psychiatry patients, this actually takes the form of a disorder. So that could be another factor which is leading to the increased prevalence of the insomnia with the aging. Then thirdly, as we age, we experience different kind of life events. Many of the life events are negative, many of the life events are positive. And say if we are very sensitive to these kind of emotional changes, then that can lead to the disruption of the sleep-wake circuitry and in the brain, and that can precipitate insomnia. Now, with this background of the epidemiology and the effect of the aging and the gender on the insomnia, we'll try to examine the latest concepts with pertaining to the insomnia. So if we look at the International Classification of Sleep Disorders, the second edition, which was proposed in 2005 or maybe 2000, we can say 2005. So they divided the insomnia into two major categories: primary insomnia and secondary insomnia. In the primary insomnia, they classified insomnia into four subcategories: the acute insomnia, or which was also called as adjustment insomnia. And this kind of insomnia usually thought to occur after a stressful period or after a stressful event. Then second was the idiopathic insomnia, and as the name itself suggests that we did not know about the idiopathology of the insomnia. And this insomnia was thought to occur because of the disruption in the sleep-wake neurocircuitry in the brain. And it was thought to start at the adolescent age and considered to continue throughout the life. Third one was the psychophysiological insomnia. As the name suggests, there is a change in the psychology leading to the physiological changes. So this was thought that some people with the insomnia, they developed some kind of negative behaviors associated with the sleep when they are not able to sleep. For example, the people, when they are not able to sleep, they spend long hours in bed. That lead to the negative association with the between the sleep and the bed. And now when they go to bed, their brain perceives that, look, the bed is a place where I have to stay awake. I'm sure you can recall the classical Pavlovian experiment where we have seen that when we combine two stimuli, the bell and the food, and a dog gets the salivation, and after few of these trials, even in absence of the food, when the bell is rung, the dog anticipates that it would get the food and start salivating. So similar kind of negative association occurs between the bed and the sleep in psychophysiological insomnia. And fourth one was the paradoxical insomnia, or also known as sleep state misperception. So in these cases, when you examine the sleep objectively using polysomnography or actigraphy, you would find that the person is actually sleeping, but subjectively person would say that he or she is not sleeping. Then the secondary category were those issues which were considered to play an etiological role in occurrence of insomnia. For example, insomnia associated with fever, insomnia associated with say osteoarthritis. So that considered that had the person not been having the osteoarthritis, he would not have suffered insomnia. Similarly, for psychiatric disorders like secondary to depression, secondary to anxiety, secondary to schizophrenia, then substance abuse, for example, see alcohol withdrawal, benzodiazepine withdrawal, cocaine intoxication or cocaine use, and so on. And fourth one was the insomnia secondary to poor sleep hygiene. Sleep hygiene concepts we will discuss later, but in short, sleep hygiene concept suggests that every person has to maintain a good sleep hygiene. That means has to practice some behaviors which would promote falling asleep and staying asleep. For example, you turn off the light before going to bed at least half an hour, at least 2 hours before you dim the light so that the melatonin can be secreted, which help you to promote falling asleep. You do not use any kind of screens before 2 hours of going to bed. Do not use any kind of stimulants like caffeine, cola, or coffee before going to bed, or at least 4 hours before going to bed. So all these are the different kind of sleep hygiene techniques. But in 2013, with the advancement of the understanding of insomnia, we found that the people who are suffering from either primary or secondary insomnia, or maybe different categories of even the primary insomnia, they were actually having something which is in common. So the people who were classified as different subtypes of primary insomnia or in the secondary insomnia, they have multiple things in common, and the difference was subtle or more artificial than actual. So that led to the clubbing of insomnia into just two categories: short-term insomnia. That means the person is having difficulty falling asleep, staying asleep, or waking up earlier than the desired wake time, 2 or more nights a week, and the symptoms, they are present for less than 3 months. And similarly, if the symptoms are present 2 or more than 2 nights a week, and they are present for at least 3 months or more than 3 months, then we call it chronic insomnia. Of course, daytime consequences has to be present because of the insomnia when we are diagnosing either the short-term or the chronic insomnia. Now, I just mentioned that the different people who have been diagnosed in the different subtypes of insomnia, they have something in common. So this was a study which was published in 2012 in Sleep. It's one of the high impact journals in the area of sleep medicine. So they took 60 participants, 31 suffering from psychophysiological insomnia, 30 from idiopathic insomnia. As you can see here, there is more or less they are having the similar kind of demographic data, and the alcohol use is also similar between both the groups. The severity of depression is also similar across the groups. Level of anxiety is also similar across the group. And when we look at the quality of life, the physical as well as mental, it is also comparable across the group. And if we look at the sleep quality measures, they are also similar across the group. If we look at the insomnia severity index or dysfunctional beliefs, they are also similar across the groups. So what does this suggest? This suggests that perhaps the insomnia the subcategorization into different kind of subcategories or subtypes of primary insomnia is more artificial than actually actual. So if you look at the sleep effort scale, you would see that people with psychophysical insomnia and the idiopathic insomnia, they differ only on three measures. One, the people with psychophysical insomnia, they say that they put too much of effort to fall asleep. They get anxious when they are before they go to bed, and they feel anxious that whether they would get the sleep or not. And they also worry about the consequences of insomnia more compared to that of the idiopathic insomnia. But uh, the other measures, for example, whether they have the control over their sleep and wakefulness, whether they put off going to bed just because of the fear that they would not get the sleep, and they worry about the sleeping, and whether they consider themselves as they have lost their control. Across these kind of factors, both the groups were comparable. So if we look at the illness perception questionnaire in this study, you would see that people with idiopathic insomnia, they would consider their insomnia slightly more persistent compared to the people who are suffering from psychophysiological insomnia. And if we look at the acceptability to the treatment, to either the behavior therapy or the pharmacotherapy, you would see that people with idiopathic insomnia and psychophysical insomnia, they almost have comparable acceptance to the treatment of the insomnia. So that suggests that the subcategorization into different subtypes is more or less artificial. Now, this another study which was also published in Journal of Clinical Sleep Medicine in 2013, it included the psychophysiological insomnia, paradoxical insomnia, and good sleepers. And this study found that the people in the having the psychophysical insomnia, according to sleep diary, their total sleep time was greater than that of the paradoxical insomnia, and the sleep efficiency was also greater. That means people who are suffering from paradoxical insomnia or the sleep state misperception, they somehow perceive that they are sleeping less when actually they are sleeping. If we look at the polysomnography data across the nights, you would see that this data is comparable across, between the groups and within the groups. If we compare the data regarding the sleep onset latency, you would find that the people with the paradoxical insomnia, they are having greater sleep onset latency, and their total sleep time is actually lesser. Their total wake time is greater, and their sleep efficiency is lesser even during the naps. So what does this suggest? This suggests that insomnia is basically a 24-hour problem. It is very rare to find a person who is actually having the clinical insomnia who would say that, look, doc, I'm not able to fall asleep at night or stay asleep at night, but during the daytime, my sleep is real good and I can take a good nap. The moment somebody reports you this, you should actually think about, thinking of a alternative diagnosis rather than insomnia, because insomnia is actually a 24 hours problem. So these people, they are having poor sleep at night and they are having poor sleep during the daytime as well. So this was a small study of the major depressive disorder patients that we did. We found that 72% of them, they were reporting insomnia. So when 30% of them, they were not having insomnia. When we tried to categorize the insomnia in primary and secondary, we found that nearly 40% their symptoms were meeting that of primary insomnia, and the 60% patients, they were meeting the symptoms which can be categorized, where they could be categorized as secondary insomnia. But what was more interesting, that nearly 33% they had symptoms where which were fulfilling the criteria for primary as well as secondary insomnia. So we gave a term combined insomnia. So this is another evidence which suggests that the differentiation between primary and secondary insomnia is more artificial than actual. So in summary, what are the changing concepts? Now we diagnose insomnia as a disorder, whether it is present or not, or if the person is having insomnia symptoms, we also record that. And we just say whether the insomnia disorder is present alone or it is comorbid with other medical conditions. So, for example, rather than secondary, we use the term insomnia disorder comorbid with depression, comorbid with anxiety, comorbid with osteoarthritis, comorbid with diabetes. If we look at the prevalence of comorbid insomnia, friends, I think you will be able to recall that in general population, the prevalence of insomnia disorder was found to be somewhere around 10%. But if you look at comorbid insomnia, that prevalence goes as high as 90%. That means most of the patients that you are treating as the primary care physicians or as a specialist, many of them, they are actually suffering from insomnia. And what are the common disorders associated with insomnia disorder? A number of psychiatric conditions, as I have already mentioned earlier: depression, anxiety, substance use, schizophrenia, bipolarity, and so on. Similarly, common medical disorders like hypertension, CAD, cancer, stroke, diabetes, fractures, respiratory disorders like ILD, COPD, chronic pain, Parkinson's, multiple sclerosis. I mean, there are a number of disorders which are associated with insomnia disorder. And if we do not treat the insomnia associated with these disorders, then the things, they go haywire and they worsen. How? We will see in subsequent slides. But before that, we will look at the Indian data. So Bhaskar et al., they examined the prevalence of insomnia in patients who were attending the family medicine OPD, and they used Athens insomnia scale. They found that 1/3 of their patients, they were actually suffering from insomnia. Jayasuriya, they screen around 17 adults patient attending the primary care. They diagnosed insomnia using the insomnia severity index, and they found that the clinical insomnia or the insomnia disorder was seen in 5% of the adult patients. Basu et al., they also used Athens insomnia scale, and they found that nearly half of the patient attending the general OPD, they were actually suffering from comorbid insomnia. So just imagine, friends, the number of patients of insomnia that you are getting and maybe treating or not treating. Now, why the concept have changed, another issue is relationship. It is very difficult to establish what preceded and what followed. If you get a patient who is suffering from insomnia and also having the osteoarthritis for 2 years, it is very difficult to ascertain what came first, whether the pain of the osteoarthritis or the insomnia. Then if you are able to establish the insomnia, it had followed the onset of the osteoarthritis or Parkinson's or the hypertension and so on, then it is very difficult to delineate whether the medical disorder has actually precipitated the insomnia or acted as a perpetuating factor for the insomnia. And the issue is, if we talk about especially the depression, a number of studies, they talk about residual symptoms of depression, and insomnia is one of the most prominent symptoms of depression that does not respond to antidepressant therapy. So in those cases, we need to think that is insomnia really a residual symptom, or is it possible that person was actually suffering from depression along with comorbid insomnia? So you have started the antidepressants, you have started the anti-anxiety, so that took care of the anxiety and depression. But what was left is just the insomnia, which you did not treat. And the problem is, if you do not treat insomnia, it becomes independent of their primary diagnosis and it starts running its own course. So that is the reason the concept of secondary insomnia has been gone in the history, and we do not consider it now. And the issue is, again, why we call it comorbid. Again, we do not know whether which is primary disorder, whether the medical disorder or secondary disorder is primary or the insomnia is primary. If we manage only the primary disorders, what happens? You are not treating this part, and that becomes independent, start running its own course. Secondly, if we consider that insomnia is actually comorbid, so in those cases, you will treat the primary disorder. And once you treat the primary disorder, in a number of patients, insomnia would remain untreated. And if you start the treatment for primary disorder as well as insomnia, you would see that the response to the therapy for the quote-unquote primary disorder would also hasten. So that is the reason now we say that insomnia is now comorbid, not secondary to other medical or psychiatric disorder. Another concept which has changed in the recent classification in 2013, that earlier definition used to include non-refreshing sleep as insomnia. This has been excluded. The newer definition of insomnia says the person suffers from either initial, middle, or terminal insomnia along with daytime symptoms. Symptoms occur more than 2 or more nights a week. Less than 3 months, it's acute insomnia, or short-term insomnia. More than 3 months, it's chronic insomnia. Now, why we have excluded the non-refreshing sleep from the definition of insomnia? The reason is there are a number of other sleep disorders which are responsible for the non-refreshing sleep. For example, parasomnias, the sleep-related movement disorders, most common is restless leg syndrome, obstructive sleep apnea. All of them, they cause non-refreshing sleep. So once we include the non-refreshing sleep in the diagnosis of insomnia, that means we are ignoring the presence of these disorders, and the patients, they remain untreated. That is the reason non-refreshing sleep is not equal to insomnia according to our present understanding. Now, coming to the last part of the presentation, what are the risk factors? So cross-sectional studies have shown that the people who are having neuroticism, that means who are prone to stress, who internalize their feelings, that means who do not speak up, who do not, who would remain quite calm, not calm, but becomes quiet during the stressful situation and keep on ruminating about the problems. People who are perfect and who wants everything to be perfect in their life, people who are introvert, and the people whose ego strength is low, they are prone to have insomnia. And friends, these are although the psychological concepts, but these concepts are governed by the neurocircuitry in the brain. And we have found enough evidence using the neurobiological studies, which suggests that these patients, when they are having these kind of so-called quote unquote psychological problems, they are actually having problems with the serotonin and dopamine as well as the norepinephrine neurotransmitters circuitry in their brain that lead to emergence of these kind of symptoms and also to the insomnia, because we have already seen that these neurotransmitters, they influence our ability to remain awake as well as ability to sleep. Now, genetics plays a major role in the occurrence of the insomnia, and nearly as much as 50% of the patients, they have a positive family history. Various studies, they have found that monozygotic twins are at greater risk of having insomnia than dizygotic twins, again suggesting that genetics plays a major role in the occurrence of insomnia. Similarly, certain genes which regulate the circadian clock, which regulates the sleep and wake schedule, gene which regulate the encoding of the GABA activity. So these are the genes which actually regulate the activity of the GABA, and we all know that GABA is the neurotransmitters which keeps us calm and allow us to fall asleep and stay asleep. And the S allele of serotonin receptor gene, they are at greater risk of developing insomnia, and because of these kind of problems, the patients would be having the psychological concepts like neuroticism, perfectionism, as we have seen in the earlier slide. Now, friends, you have to understand there is a concept of sleep reactivity. Not every person develop insomnia when they are facing a stressful situation. Some people they are prone to stress, and they have high sleep reactivity. So studies have found that their sympathetic response is greater. Their heart rate changes during the periods of stress. They are highly sensitive to caffeine, and when they are admitted for the polysomnography in a sleep lab, often in the first night they are not able to sleep. So these are the people who are having high sleep reactivity, and the people who are having high sleep reactivity, they are usually prone to develop insomnia in this stressful situation. So you would find that these people, they will not be able to fall asleep or have either the middle or terminal insomnia when they are facing any of the situations that you can see here in the right side. And these are the items which have been included in the Ford insomnia response to stress test, which suggests that it's the hyperarousal which causes the insomnia. Now, when we talk about the sleep reactivity, the persons, they have different sleep reactivity. Some people, their sleep reactivity is blunted. Some people, they have high sleep reactivity. So people who are having higher sleep reactivity, when they follow the poor, they have the poor sleep hygiene, or when they suffer from a medical or psychiatric disorder or any other sleep disorder, because of the virtue of high sleep reactivity, they develop insomnia. And those who are having low sleep reactivity, they do not develop insomnia. And initially, this is basically a transient insomnia or short-term insomnia or acute insomnia. But the problem is, if we do not treat this short-term insomnia here, then because of the process of kindling, this is again a term which has been borrowed from the literature of epilepsy, the insomnia becomes permanent and chronic. And that is the reason that insomnia should be treated whenever you find it first, before it takes the chronic picture. Now, why treat? This was one of the studies and which has looked at the cost of the untreated insomnia. And you can see here that individual cost for the emergency department or the emergency medical care is around $1,500 per person. Their prescription costs around $500 per person. they are at greater risk to get admitted because of the insomnia or the other problems. So that is the reason we need to actually treat the insomnia. This was another study. So it had found that even if we look at the cost of the insomnia and the comorbid conditions, you would find that people who are having insomnia diagnosis associated with the other medical disorder, they actually incurred 26% higher cost in the baseline and 46% in the 12 months after diagnosis. So if you look at the comorbidities occurring with the insomnia cohort, that means insomnia with hypertension, insomnia with depression, they spent 80% greater on an average than the matched control cohort who were suffering from the medical disorder or psychiatric disorder, but not having insomnia. No. And then we look at the insomnia can also lead to the cognitive impairment. So this was a meta-analysis of 28 studies. They found that they included the adults with and without insomnia, and they found that the people who are having insomnia, they are slow to react, they are not able to inhibit their tasks, and their cognitive flexibility, that means changing your decisions according to the prevailing conditions, they were also lost. But what was not lost is the frequency of their decisions. Coming to again hypertension, 14 prospective cohort studies, they found that the people who are suffering from insomnia, they are at greater risk for having insomnia. Especially difficulty maintaining the sleep was greater than the early morning awakening, but there was no difference with the difficulty falling asleep. This was more common in Europeans, but not in Americans and the Asians. So these results could be related to the genetic susceptibility, the number of the studies, and the other risk factors that can lead to hypertension across the different population. If we look at the stroke, prospective studies, they have found that adults who are having the difficulty in falling asleep or difficulty maintaining the sleep, they are at greater risk of developing the stroke in at least 2 years. People who are suffering from non-refreshing sleep, they are also at greater risk. That means people suffering from insomnia as well as the other sleep disorders, they are at greater risk of stroke. If we look at the psychiatric disorders, and so in this meta-analysis, the longitudinal studies were considered where the insomnia was diagnosed as nighttime as well as daytime symptoms, and the patients were followed up at least for 12 months. And it found that the untreated insomnia increases the risk for subsequent depression, anxiety, alcohol abuse, as well as psychosis. So, insomnia is actually considered to be an early sign of psychiatric disorder, but most of the time it is actually a comorbid insomnia, or it can just be a warning signal that look, the man, you are having insomnia and you are at greater risk for having other psychiatric disorders. If we look at the other studies, if you treat the insomnia, it also improves the mood. So friends, be careful before you diagnose a person having insomnia as depression. So in summary, we can say that insomnia is prevalent, often remains undiagnosed and untreated. You should not try to differentiate between primary and the secondary insomnia. Just think about comorbid insomnia. People who are suffering from insomnia are at greater risk of having other medical disorders. Similarly, people with other medical or psychiatric disorders, because they are also at greater risk of having insomnia, so they should be screened for the insomnia. And if we look at the untreated insomnia, it has a huge social, economic cost as well as a burden on the healthcare system. So this is the summary, friends. And if you have any questions, I would be happy to answer. Otherwise, we will continue. We'll share some of the articles related to this presentation, and we'll continue discussion on the WhatsApp group. And I hope Dr. Imran and the other people from the primary agency Pulse Pharma, they have taken the screenshot for the sake of the attendance at 3 different times during this meeting. So please share this screenshot with me.
Yes, sure. So any questions, any queries from the participants? So yeah, I think we have.
Sir, I have one question, sir.
Yeah,
Like
yeah, please go
most
ahead.
of the retired persons,
Uh-huh.
what they do is like they keep on meddling with their cell phones, and during the night time, they are meddling with their cell phone, not having adequate sleep, and from the early morning, 4 to 5 hours, they have a good sleep. So is it harmful for their for their health?
Yes, of course. I mean, see, it's not only the duration, but also the timing of the sleep is also important. The reason is in sleep, we are having in during the sleep, we have two different sleep cycles or two different sleep phases, the non-REM sleep and the REM sleep that I think all of you know. Now, the issue is the occurrence of the non-REM sleep is actually tied to the duration for which we are awake. And the occurrence of the REM sleep is more or less governed by the circadian factors. So if a person is going to correct time or the right time to the bed in the night and sleeping at around say 8 o'clock, 9 o'clock, then they are having non-REM sleep, which predominates in the first half of the night. The reason is they must have been awake for say 16 hours, 18 hours, and the longer we are awake, greater the amount of non-REM sleep. But as we move towards the morningness or towards the morning, the proportion of REM sleep it increases because the REM sleep is governed by the circadian factors. So if you are sleeping at 4 o'clock in the morning and waking up at 12 o'clock in the afternoon, of course, you are spending 8 hours in the sleep. So duration is okay. But the problem is you are getting very little of non-REM sleep because because of the circadian factors, the REM sleep, it predominates during your sleep. And why this is important? Because non-REM sleep is associated with the secretion of growth hormone, which actually allows us to repair and rejuvenate our body and our organs. So if you're spending more time in the in the REM sleep and less in the non-REM sleep, then you are not allowing the repair and the growth of your body. And that can actually be lead to a number of adverse effects. So this has been best examined in the shift workers, and it has been found that the people who are working in the shift because they are having the erratic shift and at times they are not sleeping at all in the night, so they are at greater risk for psychiatric disorders. They are at greater risk for medical disorders like metabolic syndrome. They are at greater risk for stroke, and they are also at greater risk for certain cancers, for example, in the female breast cancers and in the male prostate cancers.
So I have a question.
Yeah,
What
please.
are the advantages of REM sleep?
Sir, REM sleep basically helps in memory consolidation. So whatever you learn throughout the day, it goes to the long-term stores during REM sleep.
Meeting. I have a question, sir.
Yeah, please go ahead.
Actually, in the slides, you have told in much detail about the classification of insomnia, but
Yeah.
in conclusion, you told that it is better not to bother about the primary and secondary causes, but to concentrate if they are associated medical comorbidities with the insomnia, and whether insomnia is of the acute or chronic variety.
Yep.
And so I think that is because our treatment can be classified as per these things only. We can treat the acute or chronic insomnia along with the comorbidities, and that is going to help the patient.
No, Daksab, the issue is the reason that you are mentioning is not correct. If you recall, I mentioned that there are two or three different issues. First, it is very difficult to ascertain which came first, because once I say that look, insomnia is secondary to osteoarthritis, then I have to carefully delineate that the osteoarthritis it developed first and then insomnia, which is very difficult in most of the patient. Secondly, what has been seen across the studies that if you do not treat the insomnia and presence, whether even when we used to call it secondary to insomnia, quote unquote, secondary to other medical disorders, quote unquote, then in those cases, after certain period, the insomnia symptoms, they will dissociate from the primary disorder and start running their own course.
Okay.
And insomnia becomes chronic. So that is the reason we do not differentiate between primary and secondary insomnia. We just say it's a comorbid insomnia, comorbid with hypertension, comorbid with diabetes, comorbid with, or maybe XYZ.
Okay. Thank you.
There is one question from Dr. Manoj Pujar.
Yeah.
In
So
the chat box.
medication mitigates symptoms of insomnia, or can medication compensate the quality and quantity of sleep? Of course. The hypnotics that we had at our disposal, which includes the benzodiazepines as well as the Z drugs, they have been found to restore the functioning in the patients who are suffering from insomnia. I mean, all of you must be prescribing the hypoglycemics for diabetes, must be prescribing antihypertensive for the hypertension. So, and we all know the beneficial effects of these medications. That once you keep the blood sugar in a say given range, then you can mitigate the adverse effects of the high blood sugar. If you keep the blood pressure in a given range, okay, meditation. Sir, it is very, I'm so sorry. Meditation, again, we don't have much data about meditation, whether it can mitigate the effect of the insomnia or not, and I'm not really sure. Maybe even I have to see if we have some kind of data. Maybe I'll get back to you in the WhatsApp group after searching the data.
Basically, I think sleep hygiene is important, but I think usage of benzodiazepine is needed, as you rightly said.
So sleep hygiene, you very correctly mentioned that sleep hygiene is important, but it is not the whole soul of the treatment.
Yeah, I agree with you.
Studies which have been conducted in the people suffering from insomnia, and where we just tried to manipulate the sleep hygiene practices, it has been found that the patient, they do not improve at all. Sleep hygiene is a general practice, like we say about the hand hygiene, the general practice.
Sure.
Okay.
So any more questions?
Okay. So friends, if you do not have any other question, let's disperse from here, and I wish you a happy weekend. Whatever is remaining, have a very good evening in the weekend. Sleep well, sleep on time, so that you become recharged for your coming week, because we have a lot to study in the coming week. So we'll continue our discussion on the WhatsApp group. And friends, I would really appreciate if you start taking participation in the discussion on the WhatsApp group, because we have to learn from each other and we have to learn from literature as well as each other's experiences. So please try to find maybe half an hour or so every day. Share your experiences, read the literature, and maybe this will improve your knowledge and others' knowledge as well. So
Thank you.
please try to do that.
Thank you.
Thank you.
Thank you
Thank
very
you so
much.
much.
Thank you.
Yes, sir. Yeah, thank you so much, Dr. Ravi Gupta and all the other doctors who have participated actively in this session. And this session was very informative. So I hope that all of you have learned and, have understood about the epidemiology of the sleep and insomnia. So thank you so much for the participants. And if you have any doubts or anything, you can contact me, and my number is also available on the WhatsApp. So thank you so much, and let's meet the next Sunday at same time, 4 p.m. to 5 p.m. Thank you so much.
Thank you.